Good morning. I'm Jubin from Los Angeles, University of Southern California, and we're just going to talk about some new cases of patients that we're treating with drug-coated balloons, which has kind of changed how we approach patients with in-stent restenosis and kind of given us really a option to change the recurrent sequence of repeat interventions. And I'll just demonstrate this with a couple of cases. So what we're going to talk about is how to manage these patients that we commonly see in our clinical practice. I mean, in-stent restenosis is a real problem, and unfortunately it's a recurrent problem. And once we've identified it, we're going to talk through the algorithm of how to best treat these patients in the cath lab. And the algorithm is really based on clear identification of the problem using intravascular imaging, being judicious with your lesion preparation, and then repeat intravascular imaging to try and ensure that you've adequately prepared your lesion. And now we've got, in the US, we've got the new option of applying therapy with a drug-coated balloon rather than doing a second layer of stent that will hopefully give us a more longer-term result in these patients. And so we'll just talk about some patients, and these are patients that we'll see every day in our clinical practice. And so this is a 68-year-old gentleman on his initial presentation who came with stable angina. He'd previously had surgery in 2009 with an AVR and CABG, and then actually had a repeat CABG in 2020 for recurrent angina, and his grafts were down. He's on good medical therapy, and his ventricle was severely impaired. And he came with recurrent angina, and this is his initial angiogram back 2 years ago now. And his lemur graft was open, his vein graft to the right coronary artery was open. But he had severe disease in his left main, extending down into his circumflex territory, and his graft at that point was completely occluded. So that was the target for revascularization, and that was his main issue. And I don't think many people at that point would have kind of criticized him having PCI there. And he had 2 overlapping stents in the circumflex artery going back into the left main, which improved his angina. And this is again in January 2022. 1 year later, he presents with recurrent angina. And this is what we see. There are some patients that do not do well with certain types of stents, and he developed severe in-stent restenosis of that left main stent extending into the circumflex artery. We didn't have agent approved at that time, and so what he underwent, and he already had 2 overlapping stents over that large obtuse marginal, so he ended up having balloon angioplasty, and we managed to kind of restore normal blood flow, and he was discharged and had complete resolution of his angina. And to cut a long story short, this guy recurrently presented every 6 months with recurrent angina, and every time he had the same problem. He had aggressive in-stent restenosis affecting that left main stent, and this was a real problem. And essentially we could almost kind of keep it on the clock that every 6 months after his index procedure, he'd be back with the exact same symptoms. He was really aware of when his stent was re-narrowing. We maxed out his medical therapy, and that's where we are. And so he was desperate for us to have a new therapy, and luckily we had agent approved. And genuinely, I remember seeing this guy in the clinic earlier at the beginning of this year, and I was like, just wait, we'll have an option for you later this year. And so he came back, and what we did was we brought him back for a kind of dedicated drug-coated balloon therapy. And the importance of this was that we followed the algorithm that we need to follow to treat these patients. He came in and we performed intravascular imaging with the IVUS catheter. And when we're dealing with in-stent restenosis, intravascular imaging is crucial because it kind of tells us why the stent has failed. It tells us why the stent has failed, and
and that can either be due to neointimal hyperplasia or neoatherosclerosis. The stent may be undersized, it may be underexpanded because of poor lesion preparation initially, and the important thing which I'm trying to demonstrate with this slide is that angiogram that you can see with severe in-stent restenosis could actually be any one of these pathologies or any one of these different mechanisms of stent failure. And unless you do intravascular imaging, you're not going to know why the stent has failed, and you're not going to know how to improve your outcomes to reduce the risk of that stent failing again. So in our clinical practice, I think intravascular imaging in stent failure is mandatory, because otherwise you're just setting yourself up for recurrent failure in that. There are lots of different IVUS characteristics that you're looking at, both at the nature of the new recurrent disease and also the kind of status of the previously placed stent with regards to sizing and degree of stenosis and nature of stenosis. And these are just kind of IVUS examples of what that looks like. And so this is the gentleman's IVUS that we performed at the time. So you can see in the distal stent, it's well expanded, well opposed. And this guy had recurrent balloon angioplasty with IVUS at every point to try and kind of improve these outcomes. And as you can see, as this kind of goes through, and if you can remember the angiogram that you saw, we've got the main issue is really aggressive neointimal hyperplasia. And we'll pause this and we'll just talk about it. But every time we do an IVUS, especially in stent failure, we're looking at various characteristics of both the previously placed stent and also the new nature of the disease. And so we're looking to see how long the lesion is of the recurrent disease. We're looking to see the nature of the disease. Is it calcified? Is it just neohyperplasia? Is it atherosclerosis? And we're also looking at the stent. And in that previous IVUS run that you saw that the stent was well expanded, well opposed, but actually the real disease was neointimal hyperplasia, which was really quite focal at the area of the stenosis, and that was what's causing this gentleman's pathology. And so how do we treat that? I mean, it's a fibrotic lesion. Sometimes there's a lot of recoil in these lesions, and so our general approach is, once we've seen neointimal hyperplasia, is that we know we need to modify that, and we use cutting balloons to do that. So we take a Wolverine cutting balloon and we size that in a 1-to-1 ratio to try and modify that lesion to get good balloon expansion. And we do two things. So not only do we use the cutting balloon to try and help prepare that lesion, we then also use non-compliant balloons taken to high pressure to also prepare that lesion. Once we've done that, and once the angiogram looks acceptable in terms of reduction of the stenosis, the next, and I think this is a crucially important step, is to repeat your intravascular imaging. I mean, without a repeat intravascular imaging assessment, again, you're just looking blindly as to what the pathology is, and you're not sure if you've actually modified the disease in the way that you're hoping to do. So this is so what we did was we took a Wolverine cutting balloon, and then we took non-compliant balloons to high pressure, and then we checked with intravascular imaging to ensure that the stent looked good and that the lesion was well prepared. Now, here's his final IVUS. So I don't know if there's any questions of the audience, if anyone would stop here or would do anything further, but we were very happy with these IVUS appearances. We thought we'd got a good result. The patient was very stable throughout. And essentially the last step, and this was the first time we got to do this for this patient, was to inflate a drug-coated balloon in a kind of 1-to-1 ratio in terms of sizing, and we kept that balloon up for 60 seconds to try and ensure that we could deliver the paclitaxel drug from the balloon to that recurrently restenosed stent in the area of restenosis. Now, this is the kind of new change that we've had available to us. So it's the agent drug-coated balloon. It's very easy to deliver. It comes in sizes from 2 to 4 millimeters in terms of diameter. And I think one of the key things is to do a prolonged inflation at nominal pressure to try and ensure maximal drug delivery. I think the important things to know when we're doing these procedures is we're not using this balloon to prepare the lesion further. We're not using this balloon to actually do the angioplasty. This is the final step in once we've prepared the lesion to a maximal possible way, this is the final step to just deliver the drug to that restenotic area to try and prevent aggressive restenosis. And so this is just the image of how it looked. And then here was the final angiogram. And as you can see, angiographically, we've got a much better result. And we've now delivered the drug to this area. And for this gentleman, I'm really pleased to say that actually he's doing really well. He's gone the longest he's been since I've met him without angina, to the point where I'm actually going to bring him back to the cath lab just to check, because I was just, look, we need to see what the results of this are. So in the next few weeks, he's actually coming back to the cath lab just for us to look and see what the results of the drug-coated balloon were, because thankfully, from a clinical point of view, he's really improved, and we're hoping from an angiographic point of view, he'll continue to have also improved and had a more durable, sustained result. So that was just kind of an example of how we are now adopting the drug-coated balloon into our routine clinical practice to treat these patients who are difficult to treat, have recurrent real disease, and very difficult to manage symptoms. So do we have any questions about any of that or how to use the procedure? And I think one of the important things to say is the management of in-stent restenosis is not just doing the agent balloon. It's the whole procedure. It's recognizing that intravascular imaging is essential. It's adequately preparing your lesion. It's ensuring that you've got a good result using repeated intravascular imaging to check that you've maximally optimized that previously placed stent and prepared your lesion adequately. And then finally, you've kind of gone and delivered the drug-coated balloon in a very kind of very formal way with a long expansion and no plans to do any further intervention. And I think that's the best way to ensure kind of good clinical outcomes in these difficult to treat patients. So that's just kind of one case where we used it. And I'll just show you another case just to kind of highlight the same algorithm, but also to kind of highlight why intravascular imaging is so important. So this is a 70-year-old gentleman. This gentleman was actually we treated on last week. He presented with an NSTEMI. Again, he's had previous surgery and had recurrent surgery, and he presented to an outside hospital in May of this year and with angina and PCI to his left main. He's on good medical therapy, but his ventricle was preserved. And so this is just his angiogram, and so you can see that mechanical valve, and he's got a patent graft to a distal OM, a patent lemur. And his main issue now is that stent that was placed from that left main into the circumflex in similar anatomy to what you saw earlier was, again, aggressively. So this is a stent which is now only 5 months old and has restenosed and caused him to have an infarct. And if you look angiographically, this looks very similar to what we saw before. The gentleman's almost got identical anatomy with regards to his surgical grafts, and he's got an identical area of disease of that distal left main going into that proximal circumflex. However, we need to look at intravascular imaging to understand if the disease is actually the same. So we follow the same algorithm. We use IVUS to ensure we understand the mechanism of disease, and then we prepare it based on what we see. And I'll see if I can get this to play. So this is the gentleman's IVUS run. And what we see here is actually a very different mechanism of disease. So this has been done after we've got a wire down and we actually pre-dilated just with a gentle balloon to restore flow. And what you can see here is poor expansion of the stent due to extrinsic calcium. And we'll let this play a couple of times, and this is a very different mechanism of stent failure to what we saw before. So distally, there is some atheroma, there is some disease, but no significant stenosis. The distal edge of the stent looks well expanded, and there's no distal edge dissection. And as you go through the stent, you're seeing there's a little bit of disease, but severe stent expansion. Severe problems with the stent expansion. And so this is very different to how we treated the previous patient whose stent was well expanded, but he had aggressive neo-intimal hyperplasia. And this gentleman we had to treat with very aggressive dilation of that previously poorly expanded stent. And I think this just really highlights that although the angiograms look the same in both of these patients, the mechanism of disease is very different, and the ways that we treat that are very different. And so and in this case, I don't need to use a cutting balloon. What I need to really do is expand that stent. So what we take in this case is non-compliant balloons to very high pressure to expand that stent. And we do that in a sequential way, and all based on the IVUS imaging. And what we did was he had some distal disease, which we treated with a new stent, and then we took a non-compliant balloon to high pressure to expand that poorly expanded stent. And then we again go and use repeat intravascular imaging to ensure that we've completed what we've done. And again, here is his repeat IVUS run. You can see on the angiogram looks much better, so we're all very happy with that. But what we need to ensure is that the stent is well expanded, and here on the IVUS run, we can see that previous area of severe poor expansion of the stent has been resolved, and we now have a well-expanded, well-opposed stent. And once we're happy with this, both angiographically and with intravascular imaging, the last step is to again deliver the drug-coated balloon. So once we're ready, we take the drug-coated balloon sized in a 1-to-1 fashion, and we deliver it and inflate it. And I keep mine up for a minimum of 60 seconds. And at that time, we're ensuring that the drug is being adequately delivered to a well-prepared lesion from the balloon to that area of restenosis. And here is the final angiographic result, which again shows a much better resolution of the lesion. And the patient went home the following day, at the weekend, and is doing well. And we've avoided putting in another layer of stent, which we know is associated with worse clinical outcomes. So that's what we're talking about when now we've got the kind of drug-coated balloon available to us. It's a recurrent problem. We're using intravascular imaging in a mandatory fashion to try and assess the mechanisms of stent failure. Then we're treating these lesions based on what we see on the intravascular imaging. We're expanding poorly expanded stents, we're cutting neo-intimal hyperplasia, and then we're checking our results with repeat intravascular imaging prior to our final step of delivering the paclitaxel using the agent drug-coated balloon. And I think this new technology is really going to revolutionize how we treat these patients. We're going to be able to avoid putting in second layers of stent, and we're going to reduce the risk of repeated interventions in these kind of very difficult to manage patients. So that's kind of the cases that I wanted to show.